Hello there, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. We shall today discuss rapid assessment of a trauma patient. At the end, please subscribe to our channel and give us a like if you find the lesson useful. So let us not waste time anymore, and here we go. Trauma is a bodily injury, wound or deformation occurring due to a physical force exerted on the body. The Abbreviated Injury Scale Dictionary is an anatomically based injury severity scoring system that classifies each injury by body region on a 6-point scale between 1 that is mild and 6 that is maximum. It includes more than 2000 injury codes. AIS 2015 is its newest revision, and ISS greater than 15 denotes major trauma. It involves approximately 15% of all injured patients. The vast majority of injuries are not life or limb threatening. Most of the hospital admissions worldwide with injury have ISS values ranging between 4 and 8. Severe trauma is a major cause of death in young patients. In older patients, fragility fractures are a great burden to the healthcare system. In trauma patients, it is a challenge to appreciate and diagnose the injuries at an early stage. Clinicians should note the important features such as non-accidental injury due to abuse in children and pathological fractures in adults that may be missed if not suspected and looked for. The initial assessment of a trauma patient should include clinical examination, mechanism of injury, and extent of the injury sustained. An understanding and synthesis of the interrelationships among these parameters is essential. In cases where no such correlation can be made out, that is, between the mechanism of the accident, patient's condition, and clinical signs observed, the reasons behind this picture should be searched for because the reported mechanism may have been underestimated. The assessment formula for the trauma is mechanism plus patient equal to injury. Try to find out and explore more reasons when this formula does not explain the clinical scenario. Look for obvious, less obvious, and suspected features. Trauma or injury may be blunt, penetrating, or of a combined nature. Blunt trauma is the most common form of injury seen in clinical practice. It can be subdivided into a direct or an indirect one. A direct trauma produces a localized damage at the site of injury. On the other hand, an indirect mechanism causes damage at the site distant to the place of applied force due to transmission of the force exerted. An example of an indirect mechanism is seen following a fall from a height. Here, the foot hits the ground and absorbs maximum force, but there may be a spiral fracture of the distal tibia. In this case, other distant injuries should also be suspected and investigated, such as a fibular fracture or even an ipsilateral tibial plateau fracture around the knee. Similarly, motor vehicle dashboard injury with direct hitting of the knee joint of the driver could produce a fracture dislocation of the acetabulum and hip joint. Here, there is axial transmission of the force from the knee joint to the hip acetabulum. The urgency of treating a trauma patient depends on the location and type of injury sustained. A minimally displaced tibial fracture can be treated sometime later, but in contrast, a hip dislocation is an emergency and a delay may lead to serious complications such as injury to the sciatic nerve or even avascular necrosis of the femoral head. In an indirect mechanism, if the energy is transmitted via the soft tissues or fluid, the appreciation and diagnosis of a remote injury can be difficult. For example, in trauma to the lower abdomen, the pressure wave may pass to the aorta, leading to its rupture, intraperitoneal bleeding, and sudden death. All this discussion proves that direct mechanisms are easier to understand than indirect ones. Penetrating trauma may be caused by sharp objects and by firearms. In injuries caused by sharp objects, length of the sharp object, its surface area, and the size of the entry wound are the most notable points. Local examination will confirm the extent of the injury and the need for wound exploration. The assessment of the peripheral nerve function as well as vessel, tendon, and muscle integrity is done. Prompt assessment and treatment are necessary where there is vascular injury, compartment syndrome, or joint penetration. In penetrating wounds over the thorax and abdomen, it is not always easy to establish the track that the sharp object has followed. It must be in mind that the abdominal structures at risk of injury extend higher than anticipated. In expiration, they may lie at as high as the level of the fifth rib, such as up to the dome of the liver. The magnitude of firearms-induced penetrating injuries is more difficult to understand than incisional injuries caused by sharp objects. For example, a high-velocity bullet causes extensive lateral tissue damage around its path of travel, producing permanent and temporary cavitary defects. These cavities can contain foreign material and dead tissue. The temporary cavity lasts only for milliseconds and usually is not evident during the clinical evaluation. Mind that this temporary cavity usually extends far from the area of apparent injury. Knowledge of this phenomenon enables the surgeon to carry out sufficient exploration and wound debridement. A sound knowledge of the local and visceral anatomy is also essential to deal with penetrating trauma. In road traffic accidents, a left-sided impact may result in lateral compression of the pelvis, a splenic rupture, and left-sided extradural hematoma. A flexion-distraction type seat belt injury after vehicular collision may produce chance fracture of the lumbar spine, duodenal rupture, knee dislocation, popliteal artery injury, head injury, and cervical spine fracture. Due to sudden and fast deceleration, the spine forcibly flexes over the lap seat belt, resulting in the distraction of the middle and posterior elements of the spine. After an electrocution injury, a simple looking local burn on hand may end up in posterior dislocation of the shoulder and even collapse due to a fatal cardiac arrhythmia. Dashboard knee injuries are a fairly common mechanism of trauma in passengers sustaining road traffic accidents. They can cause a syndrome of knee trauma, including soft tissue lacerations, bruising, or even rupture of meniscal and cruciate ligaments, as well as posterior knee dislocations. In all of the above situations, maintaining a high index of suspicion for remote and hidden injuries may save the patient's limb and life. Different patients respond differently to a given traumatic incident. Also, the same mechanism will cause different injuries in children and adults of different ages. Some injuries are very obvious and can be identified before the mechanism of injury is fully understood because they are visible externally. Full exposure of the body parts brings less obvious and hidden injuries to light. The bruised scrotum of a victim seen after exposure following a vehicular collision suggests a pelvic fracture. Contusion over the greater trochanter of the proximal femur, elderly patient experiencing difficulty rising up after a fall may be having a femur neck fracture and should be investigated accordingly, keeping this possibility in mind. Finger-shaped bruises on a child's arms or thighs suggest a non-accidental injury due to abuse. When the formula mechanism plus patient equal to injury does not seem to make sense, then the hidden factor may lie in the mechanism itself. The majority of alert and oriented patients report the truth, but occasionally there is a deliberate attempt to hide the true mechanism of injury in order to protect themselves or others from some legal consequences. This may mislead the clinician and prompt them to look for the wrong pattern of injuries. For example, a miscreant following a fall from a height of 10 meters occurring during a burglary may report that his calcaneal fracture was the result of a fall into a hole in the road. This misinformation can delay the timely diagnosis of a lumbar spine fracture. The lesson is that the patient's story should not always be believed, particularly if there is lack of correlation between history, symptoms, and examination findings. The mechanism can also be hidden if the patient is unable to give their history of injury. For instance, in cases of delirious or unconscious patients and in very young children. The physically and mentally challenged, including older patients, also cannot give a proper history of events. Delay, difficulty, or inability in reporting the injury might relate to a criminal background, such as child abuse or assault or non accidental injury. Situations that should raise suspicion of non accidental injury include external injuries that are out of proportion to the mechanism reported, long bone fractures in a toddler, an inconsistent or changing history, aggressive or unusual behavior of the attending person, or a posterior rib fracture. Apart from diagnosis and treatment, the clinician must also protect the patient from further harm, particularly when dealing with children and the elderly. Another important consideration is preserving evidence in suspected medico legal cases. We must record and preserve such evidence for any forensic examination in future without compromising treatment. The responsibility of reporting the suspected criminal looking non accidental injury cases to local police authorities also lies with the first clinician attending the case. In many cases, there is a lack of correlation between amount of injury, patient characteristics, and mechanism of injury. For example, a healthy looking, middle aged woman bends to lift a box and sustains a vertebral fracture of her spine, may be suffering from advanced osteoporosis with weakness of the vertebral bodies. Here, the physician should not only treat the local injury but also investigate and treat the underlying weakness of the skeleton, thus reducing the risk of a future fracture. Similarly, a pre existing undiagnosed or poorly controlled medical condition may be indirectly responsible for a serious injury. For example, a patient presenting with a head injury or a trochanteric fracture might have fallen as a result of a transient ischemic attack. In this scenario, it is necessary to identify and treat the primary cause and prevent further trauma from a later full blown stroke. After failure of the above mentioned diagnostic approach to identify hidden injury, there are two further approaches. First, look everywhere approach, and second, focused exclusion approach. The look everywhere approach involves a detailed secondary survey from top to bottom and at different time points soon after the initial life saving or limb saving treatment. In all major trauma centers, there is a whole body CT scanning protocol in place for this purpose. The focused exclusion approach is based on the knowledge that there are some specific injuries which are often missed on a regular basis. Such injuries include metatarsal and metacarpal fractures, scaphoid fractures, perilunate dislocations, and posterior shoulder dislocations. When such injuries are suspected, a detailed focused history, clinical examination, and appropriate investigations are carried out to either confirm or exclude them.